Assalamualaikum student, as we have started discussing scenarios on various topics, and we have started hepatobiliary system, in which we have already discussed two scenarios on the topic of pancreas, and today we are going to discuss some other scenarios. In our case one, there is a 50-year-old male who came to OPD with the sudden onset of epigastric pain. The pain is radiating straight towards the back. It is not relieved by taking NSAID, but it is relieved by leaning forward. This is a history in which there is sudden onset of severe epigastric pain. The pain is in the epigastric region and it is of sudden onset, as well as the pain is radiating straight to the back. It is radiating straight to the back and it is sharp. The pain is sharp in nature and is radiating straight to the back. It is not relieved by NSAID, while it is relieved by leaning forward. What is the diagnosis? What are the differential diagnosis? We will justify our answer from sudden onset of pain, which is epigastric, which is sharp in nature, as well as it is radiating straight to back and not relieved by NSAID but relieved by leaning forward. These 5 points are the characteristic feature of the pain of the acute pancreatitis. In other differential diagnosis, the pain will be not sharp, it will not be radiating straight to the back, but we will discuss it in other DDs. But here these five are the features of the pancreatic acute pancreatitis pain. Then in a second scenario, there is a 44-year-old patient with severe epigastric pain which reached to the maximum intensity in 2 hours. The pain is not relieving but it is increasing in intensity, and increase in intensity over 2 hours. It is constant. It is radiating back, straight to the back. It is sharp in nature and it is associated with vomiting. So our most likely diagnosis is acute pancreatitis. Why? How will I justify my answer? For justification, the pain is severe, sudden, and in epigastrium, radiating to back, radiating straight to back, as well as it is relieved by leaning forward, relieved by tripod position, leaning forward but not by NSAID. These 3 points are basically pointing towards these 3 points help in the justification of our answer. Now, what are the differential diagnosis of such pain? In the differential diagnosis, the life-threatening differential diagnosis is MI, myocardial infarction, acute cholecystitis, MI, acute cholecystitis, acute hepatitis, acute appendicitis. I will discuss all these one by one. These are the differential diagnosis of the pain in the epigastrium, but in the MI, the pain will radiate to the neck, the jaw, the left arm, and to the back. And we will exclude MI by doing ECG for the patient. And in acute cholecystitis, there is also sometime epigastric pain and sometime pain in the upper right quadrant. That back pain is also radiating towards the back, but it radiates towards the back of the scapula, not straight to the back but to the back of the scapula. And this pain is usually not constant. It comes after taking a fatty meal, after eating a fatty meal, and then after 30 minutes this pain relieves in most of the cases. In acute hepatitis, the pain is also occurring in the right upper quadrant, but we will exclude the pain of the acute hepatitis by doing the LFTs. In acute gastritis, the pain usually occur after taking a meal, while in appendicitis, the pain occur around the umbilicus initially, and then it shift towards the right iliac fossa. Initially the pain radiate around the umbilicus, but then it shift towards the right iliac fossa in acute appendicitis. In perforated duodenal ulcer there is also pain in the epigastrium, but with pain there will also be sign symptom of acute peritonitis, that is gardening and rigidity. Gardening and rigidity. Why gardening and rigidity? Because there will due to the perforation there will be acute abdomen, there will be acute peritonitis, and we will also exclude this pain by doing x-ray abdomen in erect posture. In erect posture, x-ray abdomen will show us air fluid level, which will be indicative of perforated duodenal ulcer. The epigastric pain also occur along with vomiting in the diabetic ketoacidosis, but in this case the patient will give history of diabetes, as well as DKA is common in type 1 diabetes. Most commonly in type 2 diabetes it occurs very rarely, but in type 1 diabetes it is most common, and type 1 diabetes is most common in children. So the age will be not 50 year, then the age will be of a young boy and of a young girl, but it can also occur in type 2 diabetes and in old people. Now how can they after before discussing the complication of the acute pancreatitis, we will discuss some of the causes of acute pancreatitis in which there is a mnemonic called get smashed. Gallstone. Gallstone is the most common cause of the acute pancreatitis in eastern countries, while the alcohol is the most common cause. Alcohol, ethanol. Ethanol most common cause in western country. Ethanol is the most common cause in western country. In toxin and drug there is another mnemonic, SAT. In SAT there will be steroid causing acute pancreatitis, azathioprine, which is an immunosuppressive drug, thiazide diuretic, and sometimes estrogen can cause acute pancreatitis. In S we will discuss scorpion and snake bite. M is for metabolic, and in metabolic, the condition responsible for acute pancreatitis is diabetes mellitus, hyperparathyroidism, hyperlipidemia. These can cause acute pancreatitis. In H, A is for autoimmune condition which also cause pancreatitis, and S is for surgery. In surgery we can, if we perform ERCP and Whipple operation, after that acute pancreatitis can occur. In hypothermia acute pancreatitis can occur, as well as in pancreatic dewisdom acute pancreatitis can occur. In dewisdom, basically the main pancreatic duct in 30 to 40% cases degenerate, while the accessory duct open in the ampulla obturator and act as the main pancreatic duct and drain the secretion.